Ευχαριστώ, κυρία Μπάκα. Dear colleagues, good morning. Today we are going to talk about the PRES syndrome. PRES syndrome, one phase of many etiologies. Why? Because when we say PRES syndrome, in the reality this is a sort of umbrella term, and under the umbrella we can find the most disparate etiologies, the most disparate diseases that can lead to the occurrence of the PRES. What is PRES? PRES is a posterior reversible encephalopathy syndrome. It is a clinical radiological disorder of reversible cortical subcortical brain vasogenic edema in patients who present with the acute onset of neurological symptoms. And neurological symptoms can be all the possible neurological symptoms. Generally, most commonly, these patients present with seizures, different degrees of signs and symptoms of encephalopathy, headache, and visual disturbance. As Kyria Baka said, the diagnosis rely on brain imaging, which usually reveals a vasogenic edema predominantly involving the bilateral parieto-occipital region. So this is where the name comes from. So it's posterior, reversible, but we will see later that this is not always the case. When I started preparing this presentation, I went to the Medline, I did a quick search, and there are around 2,000 papers coming out. The majority of these papers are case report. Why? Because many diseases are associated to the PRES syndrome. So I try to summarize the conditions that are most commonly associated with PRES. Of course, as many of us know, severe hypertension is the condition that is most frequently associated, but we also have eclampsia in adults, infections, renal disorders, autoimmune disease, solid organ transplant, stem cell transplant, blood transfusion. Interestingly, I learned about hypomagnesemia. In our practice, we can find PRES associated to tumor lysis syndrome, but also to posterior fossa tumor surgery, till the most bizarre, strange etiologies like licorice consumption and scorpion bite, which I didn't know. And a big chapter is the drug-associated PRES. So here again, I try to put together the drugs that are most commonly associated to the occurrence of PRES, and as you can see, many of them are the ones that we prescribe in our daily practice. Cytotoxic agents like vincristine, cisplatin, asparaginase, aracitin, methotrexate, but also rituximab and bevacizumab. There is even a case report of a PRES syndrome occurring in children treated with anti-GD2 monoclonal antibodies. Then we have immunosuppressive drugs like cyclosporine and, of course, other treatment like high-dose steroids, but also growth hormone replacement therapy. Pathophysiology. The pathophysiology of the PRES syndrome, it is still debate and it is still unclear. But that's why at least 4 theories have been formulated in order to try to explain the mechanism of the pathophysiology of the PRES syndrome. We know that 70-80% of the patients present severe blood hypertension at the onset of PRES. So it seems that severe hypertension plays a major role in the pathogenesis of the syndrome. Severe hypertension leads to the vascular autoregulation breakthrough. We have to remind that the blood vessel in the brain have an autoregulation mechanism which allow to keep the cerebral blood flow stable even in the presence of increasing values of blood pressure. When the blood pressure increases, the vessel makes a vasoconstriction, and it keeps the blood flow stable. But when the blood pressure exceeds the upper level, which is at around 150 of systolic disease, this mechanism doesn't work anymore, and we have a force-mediated dilation and increased flows, so a cerebral hyperperfusion, which lead to vascular injury, damage to the blood-brain barrier, and finally vasogenic edema. But we know that in 20-30% of the patient, we don't see abnormal values of blood pressure, and that's why other theories have been formulated, which are the cytotoxic theory, the immunogenic theory, the neuropeptide theory. What do they have in common, these theories? Is that whatever the agent that cause the PRES, it could be chemokines or exogenous toxins like chemotherapies or immunosuppressive drugs. It could be an inflammatory insult which leads to T-cell activation and cytokine release. It could be release of neuropeptides. But all these causes, agents, they lead to an endothelial damage and finally to the fluid leakage in the interstitial space, which cause the vasogenic edema. So the diagnosis is a clinical radiological diagnosis. We have acute onset of neurological symptoms with or without hypertension associated to MRI specific findings that now Dr. Τζαρούχη will illustrate more in details.
Dear Chairman, ladies and gentlemen, the radiologists, we are lonely people interpreting images into dark rooms, so we appreciate every opportunity we have to communicate with the clinician, and this is the case in PRES syndrome. PRES syndrome is a clinical radiologic entity occurring in the setting of specific clinical conditions. Imaging has an important role. It excludes alternative diagnosis and it confirms diagnosis of PRES. So you have a patient with clinical suspicion of PRES syndrome. Which imaging modality should we use? Someone would think I have acute neurologic symptomatology, I need quick imaging, let's do a brain CT. Brain CT is not widely recommended in PRES syndrome. In some cases, it may show areas of hypodensity bilaterally. However, the sensitivity of this method is very low. The gold standard, as already mentioned, when imaging PRES syndrome is MRI. We can have many sequences that give us a lot of information about the brain parenchyma. However, if I had to choose two sequences to do the diagnosis of PRES syndrome, I would choose FLAIR images and diffusion-weighted images. What happens in PRES syndrome is vasogenic edema. Water molecules move from the blood vessels into the interstitial space, the space between the cells, between the neurons, and in that area, water molecules move freely to every direction. What we see in vasogenic edema is areas of high signal intensity, bright areas on FLAIR images. But many conditions can give a high signal intensity on FLAIR images. The answer comes from the diffusion-weighted images. Diffusion depends on movements of water molecules. When water molecules move freely, we have free diffusion, which is seen as high signal on ADC maps. These maps are derived from diffusion-weighted images. So on vasogenic edema, we have bright signal, high signal intensity on FLAIR images and on ADC maps. We will see vasogenic edema on the subcortical white matter, the white matter just beneath the cortex. The gray matter, the cortex is often also involved, but we will rarely see involvement of the deep white matter on PRES syndrome. The lesions are bilateral, symmetrical or not. Where should I look for vasogenic edema? The answer comes from the name, the posterior parts of the brain, where the sympathetic innervation that exists is very low. There are typical MRI patterns for PRES syndrome described in the literature. We can have the whole hemispheric watershed pattern where the vasogenic edema extends through the frontal, parietal, and occipital lobes. Vasogenic edema seen in watershed zones, in border zones between the territory of the anterior and posterior cerebral arteries and the middle cerebral artery, zones that are especially vulnerable to hypoperfusion. Of course, the most typical form of PRES neuroimaging is the posterior parts of the brain, involvement of the occipital and parietal lobes. But PRES syndrome lies in other brain areas, such as the superior frontal sulcus, and especially the middle and posterior aspects of these sulcus. Unfortunately, in radiology, nothing is always typical. We have partial or asymmetric expression of primary patterns, and in those cases, at the end of the day, the radiologist results with a severe headache. Apart from the subcortical white matter, other brain areas can be involved in PRES syndrome, such as the basal ganglia, the cerebellum, or the brainstem. I want you to notice that when we have involvement of these areas, we should always have involvement of more typical areas. If we see involvement just of the basal ganglia or the cerebellum and the subcortical white matter is normal, we should think of other potential diagnoses. After gadolinium administration, in 20% of patients, we will see leptomeningeal or gyral pattern of enhancement. Well, in PRES, we have vasogenic edema, free diffusion. In some cases, we can have restricted diffusion, which means cytotoxic edema. Cytotoxic edema means that the cells, the neuron suffers. And let's look together this case. FLAIR images on axial plane, abnormal signal intensity, high signal intensity on the subcortical white matter, affecting the gray matter as well. On ADC maps, we have high signal intensity, free diffusion on the subcortical white matter, but black signal, low signal on the cortex. This is findings of restricted diffusion. And on follow-up MRI, 2 months later, we have abnormal signal intensity on the cortex. This is not vasogenic edema. This is gliosis of the cortex. Many entities, there are many pathologic conditions that we had differentiate from PRES syndrome. I will not go into details. Clues from the clinical examination or from the clinical history, and as well as radiologic clues, help us rule out all these conditions. And on PRES syndrome, on follow-up MRI, most of usually, but not always, most of the findings disappear, resolve. This is the question here is when should we do the follow-up MRI? The answer is that we don't know. There is no consensus on the literature. Usually we do the follow-up MRI 1 to 4 weeks after the onset of the symptoms, but this is something that depends from the clinical course and something that we always discuss with the clinician, and let the clinician go on.
So now, if we focus on PRES in pediatrics, we learn from the literature, and we can see that the most common condition that is underlining the occurrence of PRES are the hematological and neoplastic disease, which occur in around 50% of the cases, as we can see in this graphic and in the table, followed by, second position in order of frequency, by renal diseases. Hypertension is quite frequent. In this case, in this study, it occurred in 95% of the patients, but this is probably due because in this cohort of patients there were many renal diseases. Clinical presentation. Generally, these patients present with seizures that can be preceded by headache and different degree of impairment of consciousness till confusion. The child can complain about visual disturbance. Visual disturbance is generally a cortical blindness or blurred vision or hemianopsia. But we have to keep in mind occasionally patients with PRES can present with focal neurologic signs like hemiparesis and aphasia. Seizures. There is no specific patterns. These children can have a partial or generalized tonico-clonic seizures, status epilepticus. Some children can have just one episode, other children more than 2 episodes. There is no rule. Encephalogram is abnormal in around 90% of patients. Here again, there is no specific pattern. We can have focal or diffuse low waves with or without epileptiform discharge. Now, although the diagnosis rely on the MRI of the brain, the electroencephalogram can be a useful tool because it can help in distinguishing the epileptic versus non-epileptic nature of a neurological signs, and also it can help in detecting a non-convulsive status epilepticus. Now, this is the result of a retrospective study on PRES syndrome in children treated with for cancer at St. Jude Institution. They analyzed 37 patients with PRES out of their 5,000 children treated at St. Jude. So they calculate a prevalence of 0.7% of PRES in the pediatric oncology population. The majority of them were acute lymphoblastic leukemia, which leads to a prevalence of 1.6% of PRES in the total ALL population. They also have 5 brain tumors with an estimated prevalence of 0.3% of the total brain number of children with brain tumors. 15 out of 37 patients had bone marrow transplant, and median time from cancer diagnosis to PRES was 6.6 months, knowing that the onset of PRES is occur earlier when it follows a standard chemotherapy, and it's usually a bit more delayed when it is associated with bone marrow transplant. Now, the result of the study from the Scandinavian group, which focus on the PRES syndrome in children treated for acute lymphoblastic leukemia. Out of 1,378 children, they had 52 cases of PRES, accounting for 3.7% of children with PRES. And they pointed out that PRES onset, as we can see in the figure, is more common in the initial part of the treatment during induction phase in 54% of the cases, although they also register cases of PRES during consolidation or during the high-risk blocks. Hypertension was present in 79% of the children. The authors of this study were able to identify risk factors for PRES. As we can see in this Kaplan-Meier, it seems that children with T-cell leukemia are more prone to develop PRES compared to the children with B-cell precursor leukemia. Also, it seems that there is a higher incidence of PRES in older children compared to younger children. 63% of the children with PRES needed to be admitted to the ICU, and half of them required mechanical ventilation. Now, regarding chemotherapy, a temporary adjustment in chemotherapy was adopted in 61% of the children. And it was generally either postponement of the treatment, either omission or dose reduction of chemotherapeutic agents. The mainstay of the treatment rely on antiepileptic drugs and antihypertensive drugs. Here, the authors say that their first choice for antiepileptic drugs was benzodiazepine, followed by phenytoin, valproate, levetiracetam. Median duration of antiepileptic drugs was 5 weeks. Now, looking a little bit at the literature, we see there is no consensus on the duration of the antiepileptic treatments. And in the most studies, antiepileptic drugs were stopped once that the patient were seizure-free for at least 3 or 6 months. But other authors, for example, they don't agree and they suggest to administer antiepileptic drugs only during the acute phase and to discontinue the treatment once that the MRI evidence of edema is resolved. Antihypertensive drugs, first choice calcium channel blockers, followed by amlodipine, beta blockers, enalaprine, furosemide in various combinations. An important message is that the arterial blood pressure should be lowered gradually, with 25% of the lowering within the first hour, followed by subsequently slower reduction. And this is important in order to avoid ischemic lesions that could be due to a sudden reduction in blood pressure. Now, here the result of a survey on hematology oncology pediatric IEOP center, an important study, not only because it's Italian, but also because this is the study with the largest cohort of patients, with 112 patients with the PRES. The majority of them, 72%, had leukemia lymphoma as underlying disease, 18% had benign hematological diseases, and 10% of patients had solid tumor. Here again, we see that the most frequent diagnosis was acute lymphoblastic leukemia in 60 patients, which led to a prevalence of PRES in ALL of 2.1%. In the majority of the patients, 76%, PRES occurred during the induction phases, and in the remaining patients, it occurred after allogenic transplant. Here, hypertension was present in 70% of cases, and also worthy to note that 24% of patients had hypomagnesemia. There was also an atypical presentation and non-convulsive symptoms in 13% of patients. So, we know that PRES is considered as a benign, self-limited condition, but very, very rarely, but we have to be aware of this, life-threatening complication can occur. One of these is the cerebral hemorrhage, like parenchymal hematoma, intraparenchymal microhemorrhage, subarachnoid hematoma. When these happen, the patient presents with focal neurological deficit. So this means that if we have, in practice, if we have a child and he presented with seizures and we do the MRI says, okay, this is PRES, we still have to watch very careful the evolution of the PRES syndromes, because if, for example, in the following hours of day the patient present a focal neurological deficit, we have to ask for a new MRI because a cerebral hemorrhage can occur, and when it happens it can also be catastrophic, like for example in these cases where you see the evolution in just few hours in a massive intraparenchymal hemorrhage. Second life-threatening complication is the cerebellar herniation, which is the displacement of the cerebellar tonsil, as you can see in these pictures, maybe, below the foramen magnum, as a consequence of severe edema in the posterior fossa structures. So, when the brainstem or the cerebellum are involved in the PRES syndrome, the patient should be closely monitored for the appearance of symptoms of cerebellar herniation, such as gradual consciousness deterioration with hypotension and bilateral anisocoria. Cerebral herniation can be responsible of a secondary hydrocephalus, so it is possible that the patient require a neurosurgical posterior fossa decompression or a placement of a ventricular drain. The last severe complication is the refractory status epilepticus, which is a status epilepticus that does not respond to standard antiepileptic treatment. This is a very rare complication, but it represents the most frequent cause of ICU admission. And we have to keep in mind that in a quite high percentage of patients, we can have a non-convulsive status epilepticus, which can be detected on the electroencephalographic monitoring. So, what about the outcome? Is it PRES always PRES? Is PRES always reversible? Should we change the name of PRES? So, if we look at the main pediatric studies that we can find in the literature, first of all, we can see that we can have early severe complication in around 27% of the patients, which can have refractory status epilepticus, respiratory failure, cerebellar hemorrhage, coma, cerebellar herniation. 28 up to 63% of the patients require ICU admission. We can have recurring PRES in 5 up to 10% of the children. And what about PRES-related mortality? The majority of the study says zero mortality, but when the number of patients increase, there are rare cases of PRES-related mortality, which is estimated at around 2.7%. These 3 patients out of 112 who had cerebral hemorrhages and cerebellar herniation. Now, when we follow this patient for with a long follow-up, we can see that 10 up to 19% of the children can develop epilepsy in the long-term follow-up. Are we able to predict which one will be these children? The number are very small. They don't allow us to give us this information, but it seems from the results of the Japanese studies that children who have a persistent abnormalities at the MRI in the follow-up, like for example children with the gliosis or atrophy or with a lesional restricted diffusion, these are the children that can have the epilepsy in the long term. So now from theory to reality, just two case presentation of two children that we treated in our department in the last year. The first case is the case of Costantina, a 10-year-old girl with a medulloblastoma, classic type, standard risk. She was treated according to the COPNET-4 protocol, so she received radiotherapy, and after the radiotherapy she underwent the maintenance phase with chemotherapy, and during the third cycle of chemo with the cisplatin, cisplatin and vincristine, during the aplasia phase, but in absence of fever, the child presented with a repeated generalized tonico-clonic seizures associated with hypertension, 190 on 130. We performed brain MRI on the very same day, and the MRI showed bilateral subcortical signal abnormalities in the posterior occipital lobes, which were compatible with PRES. So please, Dr. Τζαρούχη, help us.
I suppose you can all recognize the abnormal findings, bilateral distribution, areas of high signal intensities on FLAIR images, affecting the posterior parts of the occipital lobes and the superior frontal sulcus. On ADC maps, findings of free diffusion, elevated ADC values. All the findings are suggestive of vasogenic edema in areas compatible with PRES syndrome.
So we started treatment for hypertension and for seizures and wide-spectrum IV antibiotics. And neurological symptoms and hypertension were controlled in the first 48 hours. But 3 days later, the girl started showing signs and symptoms of acute respiratory failure. A CT thorax was performed showing ARDS, and respiratory symptoms and parameter worsened in the following 6-7 days, despite the wide-spectrum antibiotic treatment, antiviral, antimycotic, and pulse steroid treatment. So the child was admitted to the pediatric intensive care unit and supported with mechanical ventilation. A BAL showed alveolar hemorrhage, and all the cultures were negative. Fortunately, in the following days, the clinical condition progressively improved, and the child was discharged from the intensive care unit. At the follow-up, the brain MRI, 23 days later, showed the regression of the abnormalities. Antiepileptic drug was stopped after 48 days, and because this was what we thought in that case was that the cytotoxic drug could have caused the endothelial damage at a multisystemic level, we decided to stop the chemotherapy with cystianur, vincristine, cisplatin that she was scheduled to receive for another 5 cycles, and to replace this chemotherapy with a less toxic regimen, which was the Temiri. No further episodes of seizures was observed during the follow-up, and today Costantina is alive without evidence of disease, no neurological symptoms except for a mild ataxia, no epilepsy, at 5 years from diagnosis. Second case is the case of Konstantinos, 10-year-old boy with a DIPG. Parents refused the biopsy, so he underwent the standard treatment with the radiotherapy and concomitant temozolomide Peros. 3 months after the diagnosis, he developed hydrocephalus, so he required a ventriculoperitoneal shunt. During the procedure, also an endoscopic biopsy of the tumor was performed, and the histology confirmed the diagnosis of a diffuse midline glioma H3K27M mutant, grade 4, according to the new classification of the WHO. No overexpression of EGFR, presence of a deletion of B10, so the patient was eligible for everolimus treatment that we decided to adopt at the moment of progression. So he continued, initially he continued the treatment with temozolomide until July. Just to know that this child was steroid dependent, and every attempt that we did to decrease and to stop steroid lead to a worsening of the symptoms, so it was not possible to stop the steroids. In August-September, the child presented with several episodes of shunt malfunction associated to partial clonic seizures, so treatment with Keppra was started. And mid-September, during his fourth episode of shunt malfunction, associated this time with fever, the neurosurgeon decided to put an external CSF drainage. 15 days later, the child presented with focal clonic seizures in the left arm and left leg with oral automatism, nystagmus, and secondarily generalized seizures. Blood pressure 155 on 90. The MRI on the very same day showed a symmetric white matter lesion in the frontal and temporal lobes and in the cerebellum, here again compatible with PRES, and the electroencephalography was pathological with diffuse slow activity with focal epileptiform discharges. Please, Lukia.
Don't be afraid of all these images. At the level of the bones, this is the TIAPG, and in the supratentorial level, forget the periventricular, the deep white matter lesions. These are findings of leukoencephalopathy in the course of the disease. The new finding in this MRI was areas of high signal intensity with a bilateral distribution affecting the posterior parts of the parietal lobes, the frontal lobes, affecting mainly the subcortical white matter, suggestive of PRES syndrome.
So here again, he was treated with antiepileptic drugs and antihypertensive drugs. The MRI 1 week later showed a partial regression of the pathological findings related to PRES, as we can see in this picture. But unfortunately, a few days later, the child presented again with seizures, coma, and he had an intratumoral bleeding, and he passed away a few days later. So this is a rare case of PRES. We were trying to find an explanation, and we speculated that maybe the external CSF drainage was responsible, at least partially, for the PRES. There are not many cases of PRES associated to neurosurgical procedure. They are all synthesized in this table. And just for your attention, there are 5 cases of children and young adults who developed PRES following the resection of cerebellar tumors. In the other cases, these are patients with external drainage or spinal epidural catheteral, what else? Ventriculoperitoneal shunt, etc. And it seems that the rapid decrease in the intracranial pressure could trigger the onset of PRES. So, PRES is rare, but it could be everywhere, even where we don't expect it. Thank you.